Not the case study, just the PowerPoint. Okay. Okay. So I have a question about persistent vegetative state. Okay. Okay. All right. So when you have a person that's in persistent vegetative state, the individual does have brain function. So we'll start with that. They have brain function, but it's not, they really don't interact with life. So the brain does have some functionality, but the person is really not aware of where they are, who they are. There's some reflex things that happen. A good example of that would be someone, would be Maria Shriver. So I don't know if you guys remember Maria Shriver, but she had a significant brain injury. And although she still had neuronal impulses, they weren't necessarily consistent with her ability to interact with folks within her environment. So, like, she could not comb her hair, she could not speak. She had a persistent smile on her face. So, although the person is there physically, mentally, that individual is not there. What apparently was keeping her alive was her tube feeds. So when the decision was made, and she was in that state, I want to say for at least a good solid 15 years at least that I can remember. And it was so significant because folks was like, how long are we going to keep her in this state? I mean, the damage to her brain is so significant. It's not consistent with, normal life phases. So what are we going to do? Are we going to leave her in this state? Are we going to leave her on this, in this condition? So what ended up happening, they took it to court, and I want to say one of the Supreme Courts. And she, if I'm not mistaken, she was here in Texas. And when they pulled the tube feed and stopped feeding her, she died within a week. So, it is kind of hard when you see movements. I mean, she had movements, but they weren't purposeful. I was trying to find that word for the longest time, but she had no purposeful movement, even though she had movement. And she smiled, and people presumed, her family members, that yes, it is very different than a coma. People presume that she was actually interacting with the folks in her environment because she did have these purposeful movements, but they were not necessarily purposeful with the environment. So that's when a person's in a persistent vegetative state. So hopefully that kind of came across through your readings that you were doing, especially when you look at someone with ALS. So as they go through that process, they start losing their ability to have purpose, whether it's sight, whether it's breathing, whether it's movement. So those things start to deteriorate and diminish. And eventually there will be complete cessation of the respiratory, the brain, etc. So that person ends up dying. They will succumb to their respective disease condition. So I wanted to kind of look at or discuss when you have somebody that is looking at pediatric end of life, because I covered the adult end of life. So when you have the pediatric end of life, their process or their trajectory of their disease is a little bit longer than that of an adult. And there's, I did hear Ms. Smith talk about, you had to think about the family members, the parents, and you also have to think about the siblings. But you have to think about the siblings in terms of their growth potential or their developmental stage of where the kiddos are at that particular time. And what that means is, if you have an infant, they will not have any concept of, this death or the grief of the family members. Whereas if you have someone that's between 3 and 5 3 or 5 years old, then that individual will, kind of perceive death as a state of being less alive, or they may think of it as the person just not, just sleeping and not necessarily dead at that state, because even in cartoons, they kill the characters, and then like in the next episode, those characters are up and alive. So they kind of have that magical thinking that may also lead to guilt, and that they may have had something to deal with, to do with the person's death process, when they would have had absolutely nothing to deal with the death itself. 1 to 2, they perceive it as temporary and that it's irreversible and that they could get back up and be alive and all of those things. So we go from no clue up to a year, from 1 to 2 years, where they're thinking, hey, this person can get back up. And then we start moving into 3 to 5 years, and it's more of, okay, did I cause this because I was a bad sibling and I treated them mean, or I wasn't as attentive? So we have to look at them taking on that particular situation as their older sibling, or maybe a younger sibling, is going through that end of life stage. So they may avoid, euphemisms about death. They may actually use play therapy that would be helpful for the students to actually, or not students, but for the siblings to help work through that process. Parents, they may be thinking it's something that they may have caused, whether it's genes, whether it's, how they live their life. So there's a lot of blame and guilt in that process. When children are at school age, then by 7, they start having that understanding like an adult. They understand that death is a final process, and they begin to ask questions that may, have some magical thinking that leads to guilt or fear. But dying is a threat to their sense of security. So we also have to consider that component. When we look at the adolescents up until about 20, they have a clear understanding about death, and the same way that adults do. So some of them will kind of search for some spiritual meaning or desire to understand what happens after death. So there'll be more curiosity related to that. So kind of the overall, whether they are kiddos, whether they are adults, we want to make sure that we are managing their symptoms. Primarily, we're managing pain. And we're watching this as the patient is transitioning from one level to the next level. So the pain management should be, patient-centered, as well as, including the family. So usually there's a discussion about, this is how we're going to manage pain. So we're going to, do X, Y, and Z. If we, do our assessment and our patient has, facial grimacing, or they're moaning, something like that, then we need to go ahead and, give the patient more pain medicine if they are unable to speak. So this is more of a collaborative approach, looking at all of the pieces, how this will impact the individual. Eventually, shortness of breath will become a part of it. Their mouth kind of gapes open, and they have that air hunger look to their face, and, respiratory distress may also be a disturbing process, because now if you've never experienced it, you're not really sure what to expect. So it'd be kind of good to kind of let the family know as they transition and move closer, to, that death process. This will be some things to expect, as well as the gurgling that may be experienced in the back of the throat. So difficult symptoms, it's difficult to see that loved one experience that, but we still want to make sure that comfort measures are key for these individuals. If they do have a fever or anything like that, it may depend on the patient's situation. It's going to be treated on a case-by-case basis. They may be anxious, they may be restless. So again, we're going to treat that anxiousness, that restlessness, and make sure that we communicate with the patient and provide reassurance. So I just want to go through a little bit of it's a tiny PowerPoint, probably about 25 slides. And it's kind of to regroup some of the things that we've already talked about, but there's a couple things I want to hit on, especially when you're looking at a DNR and what that consists of. So let me share my screen, and then we will proceed through. All right. So here, let me go ahead and then go to page 1. All right, so looking at death and dying, and minimize the chat so I can go through. So there's some end-of-life preferences. So you've been hearing about, reading about these advanced directives, which are another word for those are durable power of attorney of healthcare or living will. So some individuals have already, you know, before it had to become something more official, most individuals would talk to their family members and express their wishes. You know, if a ventilator is going to keep me alive, then I don't want to, you know, I don't want to be on a ventilator for the rest of my life. I don't want to be tied to that particular process. But then we had to start putting things in writing, because sometimes it may not be the patient's actual wishes, and you may find yourself actually honoring the wishes of someone else because they weren't quite comfortable with what their family member decided. So if a person doesn't have an advance directive, then this is going to be one of the first things upon admission that the individual, the family, will be asked to address. Then we have a do not resuscitate. Several components have to be in order with the DNR. What are they? Okay, we need a doctor's order. That is correct. Anything else? Family involvement. Okay, what else? Assigned consent. One more. And this is a really important piece to it. Okay, besides a witness. Must be current. So it has to have, you know, it has to be current, must be in date. So you can't have a DNR, and DNRs do have an expiration date. Physicians put them there. So you need to make sure that it definitely is in date. And can a DNR be undone? Yes, it can. It's a long process for that to happen, but yes, it can be undone. Usually, most family members, if this has been discussed prior, it's not undone. So, and usually if you have someone that's trying to undo it, it's because, you know, they're at a different stage of grief than where everyone else is. So those are usually the individuals that, you know, are struggling with the diagnosis. They're struggling with, you know, the overall process, the patient dying, because they haven't gotten to that phase of acceptance. So you may see that happen. Um, so let's go through a couple of examples. So you have a patient, they have a DNR for lung cancer, but the patient is dehydrated, okay? And the family is concerned about the dehydration. They're not at the end stages. This is just right in the beginning of their diagnosis. So do you treat that? Or since they are a DNR, you do not treat? So yes, the DNR is a do not resuscitate. If the hydration status is not one of resuscitative measures, then we're going to treat it. So we're going to treat the patient symptom, you know, as they supportively, as they transition from one stage to the next stage to the next. So if the patient's not in a cardiac arrest or they're not in a resuscitative mode, then they're still a DNR, but they're not a D&T. So there's no T in here, which would mean do not treat. So we treat them, but we don't necessarily resuscitate them. Okay. Then we're going to look for physician's orders for sustaining, you know, treatment. And that can vary on a case-by-case basis. I know the DNR does not count if the patient dies in surgery. What do you mean? Like if there's a loophole around it, I mean, the family can reverse it, is what I mean. If, is that what you're talking about, Jessica?
So it was a long time ago. Second semester, Miss our PNC teacher told us that if the patient goes into like cardiac arrest while they're having surgery, they usually don't follow the DNR because technically the patient didn't die of natural causes; they died under surgery. So they would resuscitate them. But I don't know if there's any other like if the patient dies like this specific way, like you can forget about the DNR kind of thing.
Surgery is a specialty, but this would be if the family just wasn't, like, the family can reverse it if they feel, and I think this is what happened with Maria Shivo, and this is why she stayed in that process for so long, is because of those purposeful movements. They were like, she understands who we are, and when we call her name, she turns her head towards us, and so forth and so on. So I think it's a case by case basis, and just to be honest, and I think there's a couple of surgical folks on here. No, people, surgery don't like anybody to die in surgery. So they will give them just enough medication and move them out to the floors. And then, no, we do not what? They've taken the ICU. So yes, even if the patient is a cardiac arrest, they're going to work that patient and slide them out. They don't want the death on their records. So I don't know if it's necessarily a loophole or just been a practice and people have just, thought about it. Yeah, we already talked about Terry Shivo. Did I say Maria Shivo? I meant Terry Shivo. Thank you. All right. So these physician orders, they're going to vary person to person. And there's no real standard order because it all depends on how the patient presents, where their nutritional status is, where they are in the disease process. We're talking about months to weeks to days. So those things are going to vary from person to person. Okay, but you do need to have those available and know what the doctor's preferences are. Okay. So let's look at advanced directives. So it's a written document that a patient makes when they're of sound mind. So this is a good thing to do, ahead of time. So that way your wishes are good. There's no expiration date on these, by the way. It's a legal document that you have with a witness, and it's signed, and it is considered to be what you prefer to have happen to your person. So your preferences, whether you want cardiac, if you want them to do CPR versus no CPR, intubation versus no intubation, ventilation versus, and when I say intubation versus no intubation, so you may be able to use a bag valve mask, but not put a tube down the person's throat. So you may only do chemical measures, which would mean all of your medications, but nothing else. So you need to look at it and see what the patient, prefers. Usually completed in advance of a serious illness, but sometimes it's not. Most common types are durable power of attorney and a living will. Looking at the next one, this is a durable power of attorney is a legal document that authorizes somebody. They usually have an executor to make the decisions on their behalf when they are unable to. And it doesn't necessarily mean it's going to be the person's significant other. It may be a different individual that the person who has this durable power of attorney entrusts to make the right decisions for themselves, because the significant other would be too emotionally distraught to actually follow through, or may, chicken out. So here, this is a healthcare power of attorney or medical power of attorney or a proxy directive. Living will, again, this is someone's preferences for treatments. It's often accompanied with a durable power of attorney, or also known as a medical directive. But either way, these are instructions that are being given that the signer is terminally ill and not able to communicate their wishes directly. So it'd be good to, talk to your parents, your husbands, your wives, to say, hey, if anything ever happened to you where you're unable to make decisions for yourself, what would you like? What would you not like? So that way that you don't have to now face that process and make that decision when you're already under duress. So this goes back to what I said about the DNR. So some settings, the term allow natural death, and which is the A&D, which is allowed natural death. And this is used in place of a do not resuscitate. So that there's a couple of options. But if the patient's constipated, then we're going to treat them for constipation, as that is not related to resuscitation. And I gave the example, if the person's dehydrated, we're going to treat them with IV fluids, because that's not related to resuscitative measures. So it must be in date. Only use if the patient is in a resuscitative state. That was why that R was there. So here, these orders are transferable across and readily available to healthcare providers. Let me find this question real quick. Somebody's in the chat. End date, is that a year? So some of them go longer than a year. So however it's dated, so if the physician says, and then I think they're going to base it on if they feel the person's going to survive a year or not survive a year, but it still must be within the time frame that you're treating the patient. So if you know they have it, then medical tag bracelets, then you need to find the if it's expired or not. And the one thing about pre-hospital, the patient may be a DNR, but if they can't find it or no one knows where it is, then they're going to actually treat the patient until they have that order, because it needs to be visible. So you need to verify that there really is truly a DNR. And if someone is, it should be in the household, usually kept in a folder, so that it's easily accessible when needed. If the patient has been seen at the hospital prior, or there's previous records, then that information will also be in there through the medical records. But you still have to see, it should always have a physician's order and be in date. So this is just kind of letting you know what a physician's orders are for life-sustaining treatment, what color it is, but this will identify, CPR measures, IV medications, antibiotics, fluids, any nutrition. So basically what's going to be the patient's interventions while they're going to be under your respective care. It's signed by the patient or surrogate, the physician, an advanced practice nurse, or a physician's assistant. So all of those will be legally binding, and it's going to be subject to state laws and regulations. So not all states have endorsed this particular form, but they may have a similar form. So still, you need to ask for any physician's orders related to life-sustaining measures.
Ms. Hudson?
Yes.
I have a question. Okay, so I was doing a practice question over DNRs and stuff, and I just wanted to, I guess, get a little more information or clarification. Let's say I have a DNR in Texas. If I go to California and I'm in the hospital, does my DNR in Texas count for the one in California, or no? Do I have to get a DNR in California as well? Like, does it cross states, or?
I don't see why your DNR in Texas would not count in California. It's your DNR. It should follow the person, not necessarily the state.
Okay.
So it's not DNRs are not state driven, they're person driven.
Okay.
But the orders, that's different, because the orders are going to depend on state by state, because it'll be based on physician. Does that make sense?
Yes.
So if the physician doesn't have a licensure to practice in California, then you would probably need new orders, and they would dialogue with the physician from another state, but it'll be that practicing physician in California. Does that make sense?
Yes.
Okay.
Ms. Hudson, I have a question that kind of relates to that.
Okay.
When I used to work in a nursing home, when we would get like new admissions, I just remember the paperwork for those DNRs would actually state at the top, Texas do not DNR order. I don't know if it's just the form itself may be different from another state. I'm not sure, but I do remember like some of the forms that actually say Texas DNR status form.
So if you have a DNR, which is basically, if you have it in your living will, then that is transferable to wherever you go, because it's now if the person just has a Texas DNR, then that's different. But and that may be depending on how the form is filled out or how it's laid out. But I know when my mom did hers, it wasn't just for Texas. So She had a living will. She did her advance directives. She did her durable power of attorney. It was all in one legal document, and there was nothing that prevented her, if she was to die in another state, for that not to have been honored. So it just may be the form, but I can check that for you. All right, so how do we deliver unpleasant news? Who should be delivering the news? Let's just start with that. Whose responsibility is it? It's the doctor's responsibility. So do not get yourself booby trapped into answering questions that the physician should be answering. Why? Do you know everything about that condition? Do you know the treatment that's going to be done? Yes, it's a legal issue. It's almost like surgery. If a person's having surgery, it is not your responsibility. You are not proficient in surgeries, that particular surgery. You have no idea how they're going to make the incision and what instruments they're going to use. So, even if the doctor is, all bent out of order, it's his or her responsibility to, first of all, tell the person what their final diagnosis is. Now, you're in the room for support. Okay, so you're there, one, for you to be educated on what's going on. Two, what's the plan of care for this individual? So this is going to be a multi-team approach, and they may bring in some other folks or say, we're going to have these folks come in and see you. But when that person is receiving the news of what their diagnosis is, that is all the physician. Okay, so when you have more people involved, this does give that environment that, everyone is caring about your situation and what's going on with the individual. Give them time to ask questions, and at the time, the patient may not know what questions to ask. So sometimes you could kind of lead that process and say, well, how are we going to do nutrition? What's the next steps? Or just say, what are the next steps for the patient? What should they be doing? What are we going to do? Does that make sense, to kind of facilitate and advocate for your patient? Give them time to cope with the information. So, it's a lot to process. And the first thing people think of, depending on what the diagnosis is, how many days do I have left to live? What about, they start worrying about all their life issues outside of the hospital, and it may not necessarily be in correlation with them being healthy or trying to get better, and they may not be in a position to get better. So here's some things to think about. We always feel as though if there's quiet in the room, that it's, it does make you uncomfortable. And so you try to find something to talk about. Let the quietness sit, because sometimes there just isn't anything to say. And just let that whole situation sink in for the individual. So don't feel the need. So resist it to always try to fill up that empty space with a bunch of chitter chatter. Okay. Give the family and the patient time to reflect on the information they just heard and questions. And they may not have them then, but they may come back in 15, 20 minutes, 2 hours, 4 hours later, a whole day later, and have a barrage of questions that they want to know. But then you need to get the physician back in there to answer those questions. Just say, do you need more time to think about this? I'll give you, an hour. I'll come back and check on you in an hour. If there's something that you have to do with the individual, avoid distractions, avoid any impulse to give advice. You're supposed to be that objective party. Avoid things like, I know just how you feel, because really, unless you've experienced what they've experienced on some level, then you really don't know how they feel. But what is a better question you could ask them? you can ask them, is there anything I can do for you? Tell me how you feel. Is there anybody you want me to call? Those would be some words that, you know, additional family members, you want us to call your pastor, your priest, your rabbi. I mean, those are things that you can actually, you know, ask the individual. But, you know, try to stay away from injecting any of your beliefs uh, or what you think the patient wants to hear. Try not to do that. And then look at their understanding. Look at your understanding. Do you understand what you know, do you understand what the patient's experiencing? Because they're going to go through a lot of restlessness and, you know, restate things of what they're saying, summarize things of what they're saying, so that way you can kind of gauge where they are. So, questions about this? Okay. All right, so we did talk about palliative care, but just kind of honing it in. All of this care, DNR care, could be in or out of the hospital. It could be in an acute care facility, it could be in a rehab facility, or it could be at home. Usually, most older people tend to want to be at home and die at home around things that are familiar, family and friends. They don't want to die in a sterile environment, kind of like they're just out there in the wilderness and nobody is anywhere around, you know, anywhere around that individual. So, palliative care can be delivered with, you know, end of life care. It could also be delivered with terminal care. So we're just the focus just begins to switch as you get closer, or that person gets closer to death. So we use it depending on the survival median. And actually, you know, palliative care is kind of new in reference to in reference to treating patients. Most people don't receive it because they don't know about it. But as far as the palliative care area is concerned, they would like to be involved earlier on in the process versus, you know, calling them when it's at the last, you know, the last stages, so that they can support the family through the process. But usually they call palliative care for your oncology folks, but it could be used in patients with heart failure, you know, ALS. I mean, all of those exemplars, this could be applicable to, so not just for cancer folks. So communication, so this is actually in your book, it talks about comfort and how to, you know, communicate with your patient, how to respond and be real sensitive. So if a patient's asking you, hey, am I dying? Then, you know, you make eye contact with them and follow the statement, acknowledgement, you know, acknowledging their fears. You know, this must be very difficult for you, because you can't really answer that. And then ask them about, you know, what is really on your mind? Is there something specific? So yeah, they want to know if they're dying, but that is really up to the physician to say, because, you know, that this can lead to death. That is true. However, we don't know what that time frame is. If they asked to pray with them, can we do that? You know, I don't have a problem with it. I don't believe there is a law or a rule to say that you cannot. If you feel uncomfortable about it, then just say, you know what, let me get somebody in here with you, you know, to pray. Sometimes you get to stand off to the side and just don't say anything, don't do anything. So, you know, patients may ask that of you, you know, can you pray with me? Don't be the person leading the prayer, but, you know, get somebody in there that can lead the prayer process and you be in the room and still show support. Does that make sense? Okay. So we're there more as a support mechanism to help with that transition, to clarify questions, to be reassuring and be realistic, but don't shoot somebody's hopes down. Does that make sense? But don't say, oh man, you're going to recover from this and you're not going to die. That would be that would not be the truth. Just give them hope from stage to stage to stage of things that would be true. Hey, we're going to start this treatment and We don't know where it's going to go. We're hoping that, you know, it could either slow this progression that you're experiencing. So would that be a lie? No. So we're just basically saying, hey, we're going to try this and see if it works. And then we're going to go from there. We'll move on to the next piece. Hospice care. So this is when you're now down to that terminal process. There is no cure. They've tried the treatments. The treatments have not, they may have initially had some positive results. And, you know, upon further testing, maybe the condition has now, you know, affected another body system, and it's now raging war in that area. So at this point, they realize it doesn't matter which of these treatments we do. I mean, we could keep doing different chemos, but the truth of the matter is, will this help? Is this an aggressive form? Or, you know, if this person's kidneys have started to fail and they had heart failure, and now they're starting to see multi-organ system dysfunction, this is not a cure, you know, if that process continues. So, you know, death has to be accepted. We don't have an option. We can't say, well, you know, this may turn around. You can't say that, okay? Radiation can be a part of palliative care. So, and some people will choose to, and some people will choose not to do it. And so this will be in relation to cancer. We'll just, you know, address that. So you can have 2 different patients. They start palliative care. You know, the physician says, we will try this. This will be palliative only. This is not curable. You know, we hope if we do get some positive results, okay, great. But they are also going with worst case scenario. So they can do radiation, they can do chemo, they can do all of those things to see you know, how the patient's body respond, if it's something that they can actually eliminate. So because palliative care is kind of out there, if you had a 3-ring circle, this would be on the outer bands of that 3-ring circle. And then in that middle band would be more of your end of life care as the patient shift. Those 2 can be done concurrently together. Even if they are having end of life, they may still do some treatments to assist in the process. So it doesn't mean that it's completely out. So the patient's total care is best managed by a multidisciplinary approach. So that'd be nutritionist, social worker, case manager, etc. Getting all the pastor, so getting the religious person in there. Pain and other symptoms of terminal illness must be managed. So they're going to make sure the patient stays comfortable, and then they're going to look at, you know, the individual as a transition from one piece to the next piece. Then medication regimens may be either more frequent, or they may be on like a fentanyl patch, so that they're getting that constant pain patch or pain management. And they may add in some additional, depending on the patient, if they have some breakthrough pain, because, you know, we don't know exactly how this process is going to go. They'll look at, you know, moaning, they'll look at facial grimacing if the patient can't necessarily speak, as a methodology to manage pain. But then they also need to look at respirations and how that's going to affect that as well. So kind of review, you know, the patients should be viewed and the family should be viewed as one unit, because not only are you treating them, but you're going to have to be emotional support for the family members and kiddos. Patients may want to go home and die. So now how do you set that up for that to happen? So, you know, do they have a specific room that they could utilize? And then you need to get in, you know, get a hospice care organization set up, but that's not going to be us. That's going to be who's going to do that? Social worker and case management. So it's going to be those individuals. And then they'll look at the beds and supplies and all of those things they're going to look at to make sure that, you know, everyone is on the same page. You can do bereavement care. So give them names of support groups that can also help them, you know, continue to do the research and education to see, you know, how do patients fare off? Because that is one of the questions they ask. What is the, and most doctors will just come out and say, what are the percentages of people that survive this illness at this stage, and kind of what the process is. So they usually have information about that. But, you let the patients continue to do as much as they can do until they can no longer do. The hospice can be in either the hospital or at home or at a rehab facility. So it just depends on, where they want it to happen. But if you're doing it in a hospital care or an acute care or rehab facility, LTAC or anything like that, remember, they're paying for that process too. And there's not a whole lot of Medicare dollars, especially for an elderly person, that will support them being in a facility. So this is why most people are also choosing to die at home and not even use any of their savings or their 401k or anything like that to pay for those facilities, because they can do this at home and be comfortable at home in familiar surroundings. So you didn't have to now try to bring the home to the facility. They'll just be where they want to be. Some people don't feel comfortable with the person actually dying at home. So, that's another process that, to try to help work the family through that, because that may be a point of contention. So yeah, this person may want to be home, but they may not want to, they may not feel comfortable being in that home after the person expires. And then there's a whole nother set of arrangements like funeral homes and things like that. So as the person gets closer, then they'll start making those arrangements with, the local funeral home services. And they'll say, hey, when this happens, give us a call and we'll take care of everything from that point on. So those conversations are still taking place. So, just thought this was kind of interesting. In the United States, there's, there's the whole end of life. There's not a whole lot of, a wealth of information, but there's not full integration of end of life care. And they're starting to kind of build that particular area. No. Who pronounces you? It's going to be the coroner. I mean, not the coroner, the funeral home people. I was like, what is the people's names? So, couple things. If you have a person die at home, then like when my aunt died at home, the funeral person, the mortician guy came to her home, pronounced her, took the body, all that, and took it directly to the funeral home. And then her physician signed off on her death certificate because she had lung cancer. So if you die at a hospital facility, then there'll be a physician that will come in, and that physician will pronounce you. And then now it'll be between the morgue and the funeral service what happens next. So they work that piece out. So it'll go from there. But yeah, we didn't call a coroner for my aunt. It was the mortician did it. But that was in Connecticut, so that may be different in Texas. So looking at the rest of hospice care, a lot of times it's not really understood, but it hasn't been fully integrated into the mainstream portion of healthcare. And here's some reasons why. Reluctance of the physician to refer patients. Patients are reluctant to accept this form of care. There could be difficulties, or the patients and the families don't fully benefit from the comprehensive process. And that may be from an insurance standpoint. So the goal is basically to allow the patients to stay at home, be surrounded with people and things that they feel is important to them and throughout their life. So this is why I said, hospice isn't utilized because it may not be paid for, or if it is paid for, it'd be so much money involved. And some people just don't prefer it. Things to consider: patients' wishes and religious and cultural beliefs. So, some of those things may not all be accessible in a hospital setting as they would be in a home setting. So if they wanted to light a candle, can we let them light candles in our facilities? We can't. So, in your book, it lists out, you can do a battery operated one, you can do an electric one, you just cannot do um, a fire one. Now, what do you mean by in the chapel? That they do it in the chapel? That's attached to the hospital? Okay, so is there oxygen in there? Like an oxygen? No, no, there's not. The reason why they don't allow them in the rooms is because of we have oxygen regulators and things like that. And every facility is different. So some have allowed, live fire candles and some have not. So it just, but not in the rooms, just in the chapels is what I'm speaking about. They're not going to allow you to lay fire in the room. That I can tell you. So other things we can do is use open-ended questions. Allow the family to, kind of get their concerns. It also gives you an opportunity to see what types of misconceptions they have and how to clear those up. Not at the NCLEX hospital. You mean no for fire. That is correct. It'll be no for the fire in the NCLEX hospital. Look at the collaboration between, the physicians and the other care team members. So this is why we're using those open-ended questions. And then what are the patient's goals? This is really about the patient, their comfort, and kind of dying with dignity and making sure we have, integrity related to that. So we're trying to keep the patient's goals at the forefront of all of these processes. We're looking at managing their physiological responses to the illness. So, symptom management, the pain, the shortness of breath, as they take that turn towards death and they're approaching death, what are we looking for? We're also looking at their nutritional and hydration status. And usually when we're looking at a serious illness, they're more anorexic and cachectic, which is where they have a loss of that muscle mass, and maybe no fat loss, but they have muscle mass loss. So when we're looking at anorexia, that's more disturbances of our carbs and our proteins and fat metabolism. And so as they become more dehydrated and less fed, they have less energy, which is asthenia. They may use, especially in the earlier stages, to help stimulate a patient's appetite. So Magestrol may be used, or Magestrol acetate. So your book lists several medications that can be used to stimulate appetite and things of that nature. For cachexia, then this is an anabolic and catabolic change in the metabolism. So, which is a result of anorexia. So if you kind of work with the anorexia part, then you won't have as much muscle loss to the patient. But as the patient gets closer to dying, then they don't eat or drink anything. So, they're going to go from eating solid foods to now maybe having thickened foods or pureed foods to clear liquids. And then even the clear liquids, they won't accept. So that's when, things are now moving into the next stage, because their needs and their body needs is not even on the nutritional level. So that's like now they'll stop even focusing on that piece. So how do you know they're reaching towards death? Well, they stop eating and drinking. They'll have a change in mental status, be more confused. They'll start sleeping a lot more. So you'll spend more time looking at them sleep than talking to them. They become more detached from the environment. Their vision and hearing may be somewhat impaired. You may not be able to understand anything of what they're saying. And then eventually they'll get to a point where they'll stop talking. So, but they still hear. So encourage the family to continue to talk to them, because they can hear all the way up until they just about, tap out. Urinary output starts to decrease in either volume and in frequency, but be mindful that as they start having the slowing process of the eating and the drinking, that secretions will now begin to collect at the back of the throat, just regular saliva. And you'll hear that rattling sound or gurgling sound. So you want to make sure we try to keep the mouth clear of that. Breathing is more irregular with periods of apnea. So, as the oxygen supply to the brain gets lower, they become more restless. They may feel hot, then feel cold, so they go back and forth. They may have loss of bowel and bladder. And then as the death continues to near, then they start seeing gardens and family and friends. And it's interesting, you know, each person is completely different. However, some folks may see them even before they get to this portion, you know, the people that, loved ones that have died and things of that nature. So, and even you as a family member to that individual, so say if this is your mom or something like that, you know, there may be a previous family member that may actually appear in your dreams, almost letting you know that something is about to happen. You're not really sure who it may be, but it would be somebody within that family line. So again, encourage them to, you know, to talk to the patient, touch the patient, you know, and engage with the patient, whether the patient's responding or not, but they are aware whether they're saying they are, or whether they are able to speak or not. So looking at death and after death, so things to determine whether they are dead or not, that someone will, you know, auscultate for breath sounds and heart sounds, but they do become more dusky and more blue, usually starting from the feet and then moving all the way up with the darker colored pigmentation of their skin. The blood does get darker in the dependent areas. They could be incontinent of their eliminations. Allow family members to spend time with the deceased. Once they die, then contact your transplant coordinator, especially if they were an organ transplant donor. Can do your post-mortem care, and then make sure you practice some self-care. You will get attached to patients, and even if it's for a short period of time, that is not uncommon to you know, feel for that particular individual. Do you contact organ donation for all patients? That depends on your hospital protocol. Some will say go ahead and contact the organ procurement organization to see, you know, for them to come and talk to the family to see if they would even be willing to, even if they're not identified as wanting to donate organs. So that depends on the organization. All right, so here, how do we know folks are brain dead? So when an individual is brain dead, these are usually the 3 signs that we would see. They would be comatose. They will have absence of brainstem reflexes, and they will be apneic. Other things or tests that can be used to identify whether or not they are brain dead would be cerebral blood flow studies. They could do an EEG. They can do a transcranial Doppler, or they can do a brainstem auditory evoked potential study. And so we're going to talk about the last one here. And then there's one other one we're going to talk about as well. So this measures the function of the auditory nerves and the pathways. So they put electrodes on the scalp and on each earlobe, and a brief clicker tone will be transmitted through some earphones, and the electrodes will pick up if the brain has any responses to these sounds or and record them. So this is an actual, like an electrical impulse test, but they're basically seeing if there's any electrical activity that's going on in the brain. Now they have another one, which is called the caloric reflex test. And with the caloric reflex test, this could be either cold or warm water that's instilled into the ear canal itself. And so they're basically trying to see if there's any responses that are received, you know, between the ears, and they're going to be looking at the eye movement. So if they infuse, you know, cold water or warm water, they're going to be looking for the eye closest to the ear to actually have the necessary response, or to actually respond, period. So if there's no response, then, you know, that's going to be an issue. So if they do warm water, then this should actually cause an increased rate of firing in the vestibular area, to the vestibular nerve. So both eyes should actually turn towards the opposite ear. So if I'm doing it in the right ear, then I should see both of the eyes go in the direction of the opposite ear. and then go back to the ear where they actually did the warm stimulation. If they use cold water, and cold water is like 30 degrees or below, and warm water would be about 45 degrees or above. So if they do cold water, then what they're expecting here is it'll be a decrease in the rate of the vestibular nerve firing. So here, the head will turn to the contralateral side. The eyes then will turn towards the same side for which the cold stimulus was elicited. And, you know, that would be if they had some actual response. Absence of any eye movement suggests that there's vestibular weakness. And so what would that mean? That the patient is what? Do they have any brain activity? No. So I will just say, understand that these are tests that can be used. When you have a situation where they're going to actually use this test, then you know, you actually know that this will be the caloric reflex, but they usually do cold versus warm water, but it doesn't mean that warm cannot be used. Okay, the other thing you would notice is doll's eyes. So basically, it's almost like a doll that'll just follow you as you turn the head. So, which really looks creepy. So if you ever seen like something like Chucky, then you'll understand what I'm saying. All right, so to answer, I think that was Rebecca's question. No, the DNR are not transferable from state to state. So they'll have to get a new one if they move from state to state.
Ms. Hudson, I have a question.
Yeah.
Can a patient receive palliative and hospice care at the same time, or is it either or?
Palliative care can go all the way through. So remember before, I'll answer that question about taking a patient off of life support in just a second. So let me plug up my my whiteboard real quick, and then I can show you what I mean when I say it's kind of a circle. But palliative care can be used in both pieces. But remember, as they get closer to that terminal illness, then you're just not allowing the patient to die in a painful death. Does that make sense? So that would be the palliation of making sure that their pain was managed appropriately. Whereas in previous states, or in previous, not states meaning like California and New York, but in previous phase, maybe I should use that word, before they get to terminal life or terminal care, then you could use other treatment modalities. You can use other treatment modalities to treat the individual. So you can use it with end of life, you can use it with terminal care. It doesn't have to be an either or. Does that make sense? So I'm going to stop sharing here. And then I'm going to share my whiteboard real quick. And whiteboard. I didn't have my whiteboard plugged up, so I had to plug it up. So now I will share it. All right, so here you can have, so you can have, so this could be terminal care here, right? Change colors. And then you can have end of life care here. And then you can have palliative care out here. So you're starting it here. This would be your terminal care or hospice care. This would be your end of life care. But you can use them or use palliative care throughout. How much of that palliative care is going to differ as the patient transitions from one stage to the next. So they may start here, and as they transition here, you can still use palliative care, but the focus is going to be a little bit different. So if at the beginning they started with palliative care, and I'll use my dad as an example. So when he got his diagnosis for stage 4 gastroesophageal cancer, that's what he had. The doctor said this is going to be strictly palliative. And with chemo, it was like 2 to 4 months to live without chemo. And I shared this in class last week or maybe 2 weeks ago. With chemo treatment, then that would be, at least 6 months. So that was in September, we got those results. So October, November, December, January, February is where that would have been his 6-month time, okay? So during that palliative component, he had a Mediport placed. He had a Mediport placed. He received chemo. He went through all of those pieces. He had pain medicine. So I'll say pain meds. He had anti-emetic meds. He was still mobile. I mean, he was actually still working. He was retired, but he decided to, work at the senior center because he was just sick of being at home. So, and that was before he got diagnosed with chemo. So they were doing system management, all of that was going on. When we got to the 6-month part, he went back and he had metastasis, so it had gone to the lungs and to the liver. The lungs had cleared with the chemo. So we had lungs clear. And then in the liver, there was a reduction in the size of the tumor. So we had a reduced tumor size. Okay. But somewhere between January and February, they did a PET scan. And then they found a spot on a rib, one rib. So he still continued. They changed then chemotherapy treatments. So they just didn't stop it. So now they just changed the regimen. Okay. And as they changed the regimen, they were now still trying to treat it, treat the liver, treat the one that's in the bone. But I think they kind of knew that, as we all know, bone cancer is a little harder to manage. So then he was still doing palliative care. And at this point, they were not really sure because he had already beat the odds on the 4 to 6 months with the chemo. And so they were now just going to continue with this new regimen, monitor his numbers and things like that. So somewhere along in, June and July of the next year, they really saw more increase in disease than they did in, management of the disease or slowing the disease process or elimination of the disease process. And at this point, we hit end of life. So in July, we really kind of skated through end of life and went straight kind of here. Because at that point, I think they knew in the beginning, like that latter part of June or early July, that this was that end of life stage. So when he got to that terminal care component, they basically said, all right, we're giving him about 2 weeks. So then, all of this stuff that we did all back here with the cancer regimen and all that all changed. And now we just went to, we were still looking at nutrition. We still stayed with that and just better pain management and whatever other signs and symptoms he developed. That's all we were just doing, symptom treatments. But not necessarily to improve, but to basically keep comfortable. Does that make sense? maybe thinking about it. So does that answer your question about palliative care? Because now it just moves to it shifts to a different management, but it's basically to keep the individual comfortable as they move through. I won't say it has a chance to improve illness. You know, if you get a stage 4 diagnosis, I mean, that's usually for sure your treatment may not be successful, and it falls on the may not be successful more than may be successful, but they may have had success. And so they're going to try to see if they can get success with this individual. How long can you stay on hospice? You know what? It depends on the person. It depends on the disease that they may have, whether it's heart failure or whatever the case may be. It just depends. So there is no limit on how long you can be on hospice. You're on it until you either hit a better state and you go in remission, or you expire. So who knows what time that is? Only one person, and that's God. So no man can say it's going to be this and that. And even then, they gave 2 weeks, and it was roughly close to 2 weeks. He was a little over the 2-week time frame, but still. So questions about that? Because I think I answered all of the ones that was in the chat. Last thing, would an RN ever take a patient off life support? Very good question. Is there ever a time when we can do that? Is that a part of our nursing treatment? No. So, that's usually not us that's going to pull the plug. It's going to be the physician there, respiratory therapist. We'll be in the room, but we would not be pulling it. Okay. So does that kind of help you guys with the whole end of life process? All of these are just approach to care as they transition into death. Okay. All right. So let's hit our Q&A session real quick. Since we're talking about all these different things, let me clear my whiteboard here. And then I want you to tell me, I'm going to change pen color. So tell me no, not the difference. I want the difference. All right, so I want the signs and symptoms of decorticate and decerebrate. Somebody said if only the test would be easy. Would TPN also be a part of palliative care? It depends on the individual. Let me answer this before we get to the decerebrate decorticate. There's going to be nutritional factors. So they're going to discuss that with the family. Could they do TPN? Yes, they could. Can they do things like Jevity and Boost and all of that and other enteral feeds? Yes, they can. So it really just depends on the individual. So palliative care doesn't mean that you don't treat them appropriately. It just means that you're going to start trying to meet as many of the body's needs to support the body in being able to endure the chemo, to help, do what they can to fight disease. Some people actually change their diet and go completely vegan. So there's a lot of different pieces that and do more antioxidants and things like that. So that's part of that palliative care component. Now, if we all did all those things before we, developed this dis-ease, then this would actually be great. Does that make sense? Okay, so with decorticate posturing, so usually we have what? Okay. Someone said, I think you mean adduction. So arm flexion. So we have arm, what about the legs? Do they also kind of curve inward? So they're both arm and leg flexion? Okay. I'll say leg / feet. They're gonna flex. Inner rotation. Okay, so inner rotation. Plantar flexion. Now, is that for, I think this is Owen. Is that for decerebrate or for decorticate? So, oops. So elbow and wrist are going to extend. Okay. Here we kind of got a fighting chance if we have decorticate, right? Decorticate posturing, because it's actually going towards the core. So, you know, we're hoping that things will actually work out there. Okay, so let's look at decerebrate. So with decerebrate, well, I may have written that on the wrong one. Let me just make sure. Okay, so with decerebrate, we're gonna have stiff arms and legs that flex. And we'll have wrist pronation. And then we'll have plantar flexion of the feet. I'm missing something in the chat, so let me go there. So, which of these are worse, decerebrate or decorticate? Neither of them are good. But which one is the lesser of the two evils? So at least if something's going towards the core, we still have a fighting chance. It's when things are moving away from the core, this is, we don't have a fighting chance at that time. And both of these are indicative of severe brain damage. So this could be brain damage from a stroke, this could be brain damage from a bleed, this could be brain damage from a tumor. It just indicates that that there is that the brain has been severely damaged. So when you get the arched back, is that decerebrate? What is that posture known as? Because with decorticate, let's see, we have the clenched fist, we have the bent arms, they're bent toward the wrist. Yes, epiphytonous. So this is the arched back. And that can be seen in many situations, not just in meningitis. So it could be in a brain tumor, it could be in a bleed. It's primarily seen in kiddos, infants, and young children, but it can also be seen in adults. Are they talking about the whole back arching to look like an N, Nikki? Hang on. Their head arches backwards. So if their head arches or tilt backward, then I guess that would create an arch in the back. So it kind of goes back to the epithotonus, because even with the epithotonus, they actually have their head and their feet they both tilt. And then, you know, Babinski's is a normal sign that you would have in a kiddo less than 2. Over 2, that would mean there's some neurological damage, but their feet and their head would tilt, creating a completely arched back that looks like an N. Okay. If we have, give me, who can give me or tell me what Cushing's triad is? And what does Cushing triad indicate? Okay. Okay, so give me an example of Cushing's triad. All right. Is it bradypnea? Is Cushing triad bradypnea? Mm-hmm. So, all right, so let's clarify. So let's start with, so we have Cushing's triad. Which is usually hypertension, bradycardia, and then irregular respirations. So if they're irregular respirations, I think we cleared this up initially. So we will be talking with someone that had a widened pulse pressure. So I'm just going to change color so that we can, this hypertension would be a widened pulse pressure. And that'll be the difference between the systolic and the diastolic is increased. So we could have someone with a blood pressure of 180/90. I think Kavita wrote that. Bradycardia would be anything less than 60 beats per minute. And then we have there's irregular respiration. So when they are, give me some examples of irregular respirations. And I think someone put Cheyne-Stokes there already. So we can have Cheyne-Stokes. That's another one, centrogenic hyperventilation. Any others? Ataxia. Okay. Now, just for definition purposes, so let me just make this, when you look at these, when you look at the definition, are those bradypnic respirations? Okay, what does it say? I said, so when you look up Cheyne-Stokes, for example, Is Cheyne-Stokes a slow respiratory pattern? That's what I'm asking. Okay. So it's an increase in rate and depth with apnea in between. So it's fluctuating. So it's more rapid than slow because it's an increase in rate and in depth. And that does slow down and then it increases again. Is that a correct statement? Okay. So, you know, anything above 24, so if these were 32 and irregular, oops, that's what I would be expecting if they're talking about that. What about central neurogenic hyperventilation?
Miss Hudson.
Yes.
Before we move on real quick, I've read that Cheyne-Stokes is sometimes associated with like end of life, like breathing, it sounds like rattles and stuff. Would you agree with that or?
It's usually with closed head injuries and, you know, strokes and things of that nature, traumatic brain injuries.
Okay.
So usually when you get down to, and I think it's called apneustic is the one you're thinking about. Let me just double check that one. That's the one where it's really slow.
Mm-hmm.
Yeah, that's apneustic. It's that deep gasping inspiration and expiration. So it's like that inspiration, almost like close to agonal. So go to apneustic and then to agonal, then to nothing.
Okay. Okay. Thank you.
You're welcome. But here you're now having, this is like your brain stem has been injured when you have apneustic. Okay. So, so kind of back to this piece with Cushing's triad. So central neurogenic is rapid and increase in rate and depth. Okay, so when they have respirations like that, that's tachypnea versus bradypnea. Okay. All right, so when you're going to give somebody TPA, what are some things you need to verify? What are some things you need to check? Okay, time of the stroke. And when you say time of the stroke, and yeah, you do need to make sure it isn't an ischemic stroke. I like that because if it's a hemorrhagic, that's going to be a problem. All right, anticoagulants. Okay, age. Okay, so time of stroke needs to be within 3 hours. Absolutely. Are there any renal issues you need to be worried about if you're going to give TPA? Okay, so you need to also check kidney function and all of that. So less than 3, yes, we want to make sure their blood pressure is normal. If they have kidney disease, that's correct. So contraindications, we need to understand when not to do it. If they have an internal bleed, if the stroke has been greater than, ischemic stroke has been greater than 3 hours. What if they have high blood pressure? Can we give this? Why? So what is TPA? Because someone said throw more clots. So what is TPA? It is a clot buster. So it basically thins the blood, right? But it can rupture the blood vessel if it's, you know, it's okay. So just, slow down. You guys, the information, just slow down, with what you got. All right. And so we know the difference between a hemorrhagic and an ischemic stroke. So I don't think I need to clarify that again. I think we're kind of good on the differences between the two of those. How would they present? So let's talk about how an ischemic stroke would present. So they usually go to bed, they wake up, and when you say wake up with deficits, so like the day before they were fine, but now today, and it could be midday, and they start having problems. So they didn't have an issue the day before, but now today we have some issues that we need to talk about. So they could have which kind of deficits? So say, for instance, this was a right-sided embolic stroke. How would your patient present? So weakness to one side. So if it's a right-sided embolic stroke, we would expect all the deficits to be on the left side. Perfect. So they have left-sided weakness. They could have left-sided hemiplegia of the extremities. They may not be able to follow commands. They could have slurred speech. So all of those stroke symptoms, which are listed in Brunner, table 87-2, those are the things you would look for. If it was a left-sided stroke, then they would have deficits on the right side of the body, facial drooping, difficulty talking, speaking, walking. All of those would be appropriate, okay? Now, what if they had some numbness, tingling, facial drooping, and all of that resolved in 2 hours? Is that a stroke? Okay, so it's a mini stroke, but it's a TIA, okay? It still means they need to be checked out. I agree, but what I'm saying is what kind of, what would be the diagnosis for this individual, which would be a transient ischemic attack. And then that, usually that's from high blood pressure, and it could be that the patient may be taking their medications, but the medications they're taking may not be managing their blood pressure really well. Or maybe they've had uncontrolled high blood pressure and, just didn't know that they were walking around with it, because that can also be a factor, but definitely having high blood pressure or high cholesterol, because both of those things are, indicative for, potential stroke, and the cholesterol will be due to decreased blood flow to the brain, right? So remembering those signs and symptoms, what if they had, lacrimation, facial drooping, numbness and tingling, and when you ask them to close their eyes, they couldn't? Then what is that? Bell's palsy, that is true. So Bell's palsy is really inflammation of cranial nerve number what? Somebody goes, ooh, smarty. I mean, this has been a while since we talked about strokes. Not 5, you're close. 7, that is true. It's cranial nerve number 7. So which part of the brain deals with balance? The cerebrum, the cerebellum, or the brainstem? It's the cerebellum. So, the cerebellum deals with, because remember I put that, and we're very earlier on, I had the area of the brain, that picture, or told you which areas of the brain had the different types of deficits. So you need to go back and review that, because it doesn't have to be a stroke. It could actually be a brain tumor in that area, and it's going to have those same deficits, okay? So the cerebellum deals with, balance and those fine and gross motor skills. What part of the brain deals with the respiratory and the cardiovascular system? It's the brainstem. Okay. And so what does our cerebrum, what does it deal with? Those are our three portions of the brain. Speech, okay, conscious thought. That would be that portion. Okay, so let's talk a little bit about meningitis. And if a person has viral meningitis, what's going to be the causative agent to that viral meningitis? So it's going to be a virus, but it's going to be a collection of viruses that, you know, that an individual or that you would see in the individual. So let's look at some of the signs and symptoms that you would see with, let me find my little pen here. There we go. So if we're looking at viral meningitis, and usually viral meningitis is it can actually, you know, clear on its own with some, it's still with treatment, but usually we'll start with causes would be like herpes simplex. Well, let's start with this one first and go back. So this would be enteroviruses. Enterovir. It's an enterovirus that we would actually see the individual experience. So things like herpes simplex, HIV. We're talking only about the virus, okay? Viral and bacterial are two different types of meningitises. So if I was talking about bacterial, then we would be looking at strep, so streptococcus, Neisseria, meningitides, otitis, H, influenza, B, those would be there if we're looking at bacterial, okay? So in our kiddos, you know, we would see them to change pen color for viral signs and symptoms. They would have a high fever. They would constant crying. They would be irritable. They may have sluggish presentation or inactivity. Poor feeds. Bulging fontanelle. Which one? Anterior or posterior? It'll be the anterior. And we can use that up to 18 months of age because that's when that one closes. Okay? And they can have body stiffness, so it'd be that Kernig sign and Burdinsky sign. All right. So usually with viral, when they some of these symptoms here, I mean, even though they have high fever, those are signs and symptoms. Other causes, let me go up here, would be like an upper respiratory infection. Well, that'll be over here, wrong place. Over here can be like an upper respiratory infection. So this will be their presenting signs and symptoms. So basically flu-like. Correct. What else can they have? When they first, like their early signs. So let me change this to this color. Okay, so early signs before we get to the stiff neck would be fever, vomiting, not feeling well, so not feeling well. And then they'll start, this will be kind of the early piece, then they'll start having limb pain, pale skin, their feet and hands may be cold. They develop that rash. Which rash is that? You have a couple. Yep. What rash? That's if it's, yeah, but I want to know the name of the petechial rash, okay, and purpura. So, yep. This lets you know that this is significant here. If you start getting either petechial or purpuric. Photophobia. And then we have nuchal rigidity. Confusion. So other signs and symptoms besides these here listed as to why they could have, bacterial would be like an ear infection, ear or sinus infection, or a skull fracture. Because now that's an open area. So for viral, not getting vaccinations. So like the tetanus, H influenza B. Also patients that are immunocompromised, which you can see here. Immunocompromised. So patients like with diabetes, they're at risk of developing a viral meningitis. We do look for the Burdinsky's or the Kernig sign, but recent research is showing that those signs are not they're not sensitive in kiddos less than 6 months of age. So if you have a kiddo for which they're, crying and irritable or et cetera, and your initial thought, maybe, and it may be that they're developing or that they may have meningitis, just because those two signs are not present, it doesn't mean that they do not have meningitis. It just means that that sign, there's no, it doesn't pick up. That sign doesn't show, it doesn't display. So it's kind of like a heart attack. You can't diagnose a heart attack on ECG alone. You need all of the rest of the components. So here for meningitis less than 6, you can't diagnose it based on those two signs. You need all of the rest of the pieces, which means they're probably now going to definitely need that spinal tap, et cetera, right? Yeah, that will be another vaccine. Yeah. So basically, and those are given now starting early. So within, starting 2 months of life. So along with meningitis. So folks should not be developing these conditions unless they do not get vaccinated. But, you can see the epithetonis because, as I said before, that's seen in someone that has a severe neurologic condition. So meningitis, you could see this in. You could see it in a baby that has infant with alcohol withdrawal syndrome, a brain hemorrhage, a brain tumor, hydrocephalus. It's not uncommon. Now, patients that have been poisoned, like with rat poison, the strychnine, you would see epithetonis, that abnormal posturing in those folks as well. So hopefully you don't have people that's trying to kill you to do those types of things to you. Your book gives you all of your lab values that you would need to, that lets you know when meningitis is indicative from that spinal tap, the white blood cells, protein, and glucose, etc. So make sure you go back to the textbook and know what those values would be that would be indicative of meningitis. So that would be important because you're going to be receiving those lab results and you want to know what they mean. There were, I think there was a couple of other signs. We talked about treatment modalities. How do we treat it? Q4 is the routine, but you can check neuro status as often as you deem necessary, especially if the patient's condition is not stable. So if they were speaking about a stable kiddo versus an unstable kiddo, that may be the difference there, Kristen. There was something else I wanted to say. So overall treatment, the babies, or not babies, but even adults, they would receive antibiotics. They would also receive IV fluids, corticosteroids, pain meds, and depending on the situation, so if this was like a brain tumor, they may actually have surgery. If it was a bleed, they may actually have surgery. If this meningitis was due to tetanus, then they would get the antitoxin for that. Oxygen, ventilator, those would be some things to actually help improve the patient's overall outcome. So, there are some specific meds that are routinely given depending on, if it's H influenza, if it's, Neisseria meningitis, but you're looking at penicillin, cephalosporins as kind of your mainstay antibiotics that are given. So dexamethasone would be one that would be given. Okay. Not with viral. They would, you mean for a broad spectrum? Is that what you're talking about, Kristen? Unless they know if it's which one it is. Oh my goodness. Do you guys hear that?
Yeah, don't you treat them with antibiotics as a prophylactic until you find out it's
if
viral?
It's bacterial or viral, yes. but usually antibiotics are for bacterial unless they have a viral med for them. But the virals usually usually take care of themselves, and we do the symptomatology. And I apologize. For some reason, my neighbor felt the need to burn rubber. I have no idea why they did that. So, but they're going to treat the underlying cause. They'll give not antibiotics, but they'll give antiviral medicines for those. So they wouldn't be like your cephalosporins. It'll be something completely different for antibiotic treatment. So they'll give them an antibiotic, but they'll give them a medication, but it'll be an antiviral because the antiviral is not an antibacterial. So, but all right. So let's see. Let's take about a 10-minute break because we've been gone now for about 2 hours. So let's take a 10-minute break, and then we'll finish up with the Q&A piece. So I'm glad I did extend it to 1, so that way we should be A-okay. So let's do 12:05. Sounds good? There we go. I did pause the video, so I'm going to actually go back and just, repeat what I said. So with bacterial meningitis, just make sure that, we're following droplet and contact precautions. Make sure that anyone going into the room follows droplet and contact precautions, which would mean they need to have on both a gown and a mask. And if you see anybody walking in there without both of them on or without any of them, we need to stop them and say, hey, we want the room to be dim or darkened, but not completely pitch black. So we need to make sure there is some lighting in the room. So we don't want them to be in a completely dark room with all the lights and the blinds closed. We need to make sure we're following that. If the patient has a low BP, then that means we are now in decompensated shock. So we need to address that issue. But we would expect them to have a fever and to, have nuchal rigidity, potentially have Kernig's and or Brudzinski's sign. We would expect them to potentially have a petechial rash, to be confused. I mean, that can happen, but we don't want to see a low BP because now that we're moving into shock. The last thing that I said, or just recently said, was in relationship to family being at the bedside for that confused patient. So we want to be able to identify, if the patient, or have the family identify if the patient gets out of bed, also to be there as a support for the patient as well. So we don't want them just up and moving around because we can't be with them for 24 hours. Then I was getting ready to dovetail. This is where I realized that I had not hit the resume record button. So our next place to go would be to an increase in ICP. And as there's several things, a brain tumor, stroke, hydrocephalus, meningitis, skull fracture, all of those can induce an increase in intracranial pressure. And so with that being said, what is our normal range for ICP? Okay, so 5 to 15. What if your patient had an ICP of 20 and they were awake and able to follow commands? What can we encourage them to do? We can encourage them to take a deep breath and to breathe quicker. And the reason why we want them to hyperventilate and take in those deep breaths is because when they do that, then it actually causes vasoconstriction, which will decrease cerebral fluid and also decrease blood volume. So remember that the Kelly-Monroe process. So if we have vasoconstriction, this will decrease intracranial pressure. Other things that we could also use to decrease intracranial pressure is putting the patient, giving them a cooling blanket. because with a cooling blanket, that will decrease ICP by decreasing the fever, which will then decrease the metabolic rate, therefore decreasing ICP. So if we increase our metabolic rate, we would actually be increasing our ICP. So all of those things are things that we could utilize to help our patient decrease their intracranial pressure. So yes, we don't want to cause shivering. That is true. So we don't have to have a freezing blanket on, but when you do put on a cooling blanket, then you would literally be monitoring that a lot more closely, because you're right. If they start to shiver, shivering produces heat in the muscles, which will increase the temperature, which will increase ICP. So we don't want to do that. So another thing we can also do to decrease ICP is to increase barbiturates, the dose that they would receive if they needed barbiturates, for depending on why the ICP was actually elevated. So barbiturates at higher doses will decrease the ICP. If we use, we could also use fluid volume and inotropic drugs to maintain cerebral perfusion pressure by supporting cardiac output. So we want to keep, what's our normal CPP? 60 to 80, 60 to 70, depending on which book you look at. So keeping the cerebral perfusion pressure, where it should be is what kind of our goal. What if, and don't forget how to calculate cerebral perfusion pressure, which is MAP minus ICP. And your MAP is systolic plus the diastolic times 2 divided by 3. Okay, so that's fine. As I said, depending on the book, it fluctuates. So, we still want it at least above 8. We want it around 80 is where we want our CPP to be. There was something else. All right. And that's why I said, depending on which book you read, that can definitely change. All right. So trying to see if there's any other ICP stuff I want to cover or make mention of. All right. The earliest sign that there is an increase in ICP is going to be LOC. Checking which side this issue may be on, what's going to be pupils. So the earliest sign is the patient will have a change in mental status, so it'll be decreased. And then we would look at pupils to see what side of the brain is having the deficit. So looking at the pupils, if that is another methodology of knowing if your patient has a brain herniation, and what would the pupils look like if there is a brain herniation that's in progress. Would both pupils be dilated? Unilateral pupillary dilation. So one pupil would be big, one pupil would be small, okay? So that's that unilateral pupillary dilation. So they have unequal pupillary sizes. So for kiddos, how do you know a kiddo has meningitis? What is if they're less than, say they are 1 year old? Yes, the pupillary side, yes, you're correct, Nikki. The dilation shows the side that the deficit is actually, the side of the brain that's being impacted. So that is true. All right, so let me share whiteboard. And I'm gonna clear it. All right, come on, let's clear. There we go. There we go. So for kiddos with increase in ICP, well, I did say, let's start with meningitis. So if they're less than 1, then, you know, we talked about all the fever and all that stuff that they can have. But usually meningitis would be that bulging fontanelle with a fever, right? Now, increase in ICP would just be the bulging fontanelle. And we did say this would be the anterior one, because the posterior closes at 4 to 6. Okay, I'll get to that question in just a second, Kristen. So, looking at ICP for kiddos. So let me finish up this thought before I go to that one. So ICP for kiddos, we have bulging fontanelles. What other, they would have alteration of mental status or level of consciousness, irritability. We talked about the poor feeds. I want to know what their heart rate would be. Okay, so their heart rate would be bradycardic. Completely different. So why? Aren't babies normally tachycardic? Their heart rate's usually, especially in your infant child, 120 to 160. So that would not be a sign that there's actually a problem. Okay. Kristen, to answer your question about the barbiturates, this would be in a severe traumatic brain injury. So yes, they can remember all those developmental pieces with your kiddos. So if it's a child, an infant child, they are normally tachycardic versus bradycardic. So that bradycardia would be your shoe-in or your clue that this is definitely an issue. So just kind of food for thought there. Okay. All right. I think that was it for ICP. So no formulas, you got to know that, and move on from there.
Ms. Hudson, I have a question.
Go.
I was looking at some complications. This is back to stroke, and I hate to backtrack, but it may be with ICP as well. SIADH, does that happen in both hemorrhagic and ischemic, or is it only one?
So that can happen with any type of brain injury. Mm-hmm. So, and what you're really looking for is cerebral edema.
Okay.
And if you're trying, and then you would look at sodium levels. So I'm glad you brought that up, because we're actually looking at cerebral edema as an issue or potential complication. So if you have somebody that has a sodium level of 115, 113, 112, then what are you, I mean, the next thing we're worried about seizures. We need to have more seizure precautions. And then we need to do, how do we treat it? What's going to be a treatment for that? Right, Nikki, that hypotonic solution, 3% normal saline. So we're going to give that IV. Okay. So yeah, cerebral edema is things that you definitely want to look for traumatic brain injury. So you're really looking at that sodium level and what they're doing. If that sodium level is high, then we have a whole nother process. Okay. So tell me, how would a person that's had an epidural insult, how would they present an epidural hematoma? So this would have been from the PowerPoint in your clinical.
A loss of conscious initially, and then have a lucid period.
Correct. So they usually have an immediate loss of consciousness. Then they have a period of brief lucidity. And then they will then become unresponsive again and never regain consciousness. Okay. So this is some type of a traumatic injury. So it could be from a golf ball, it could be from a baseball. And what is this, a venous bleed or an arterial bleed?
Arterial bleed.
This is an arterial bleed. So let me just put the title up here so we know what we're talking about. It's an epidural hematoma. So this is an arterial bleed. And this bleed, what artery is this, by the way? Do we know?
What artery bleeds with an epidural hematoma?
Yep. Are you asking Siri? Hey, Siri. Oh, I'm not calling you. My Siri starts paying attention.
Yes.
Turn off. It's the middle what?
Middle meningeal artery.
It's the middle meningeal artery. Okay. And that actually wraps around, it's around the temporal area. So especially close to the temporal areas where you would see the epidural hematoma happen the most often. But this middle meningeal artery actually wraps around to the occipital area as well. Oops, not A, but ox. So, you know, if a person can hit the back of their head and still have an epidural bleed, okay? So this can also be from a skull fracture. So again, taking a blow to the head, but it can, you know, we can cause a laceration of the middle meningeal artery, and that runs between the dura and the skull interior to the thinner portion of the skull, which is the temporal area. So, you know, this is a true medical emergency. That's usually an arterial bleed. And, you know, it doesn't mean that you will die. I mean, but the likelihood is definitely, you know, pretty prominent because of the fact that this is an arterial bleed. Then the other one is a subdural hematoma, or you can have that. And usually how do patients present? Well, this is a venous bleed. So this is a little bit slower, but this is no less significant than an epidural bleed. So the person can, you know, you can take a 55-year-old that's on an anticoagulant that hits their head on the corner of the door. And so, and I'm talking about the car door, so the T-post. And they hit their face, and so their face will have a lot of facial swelling. And if it's around the eyes, most people tend to focus about the eyes because they don't want them to lose their sight and things like that. However, you have to be mindful that that subdural bleed can now happen over time. So this may be like hours. So this may be hours beforehand, before you actually see something. But by the time most people catch it, if they don't get the patient to a CT scan very quickly as one of their initial diagnostic studies, then that person can end up with unilateral pupillary dilation, which basically means what? What is that unilateral pupillary dilation? We just talked about it. Besides, it's a brain herniation. So the brain stem, we have a herniation in the brain, which means that that central portion of the brain, when I showed those pictures last week, that central portion, that central line that you would normally see is now distorted. You can't see the ventricles really well from all of that swelling that's transpiring. So if and we had a couple of patients come in, they were spectators for the Dallas Stars. And, one had a blow to the head, an elderly guy. And we've made sure they came back within 7 to 14 days just to make sure that there wasn't any changes, but they're still going to be monitoring for any changes like vomiting, visual changes, difficulty walking and talking. So that would be things that they would monitor for at home. Okay. But if they take blood thinners, this can be a game changer very quickly. So subarachnoid bleed, how is that different? Yep, midline shift, yes. Subarachnoid bleed. What would patients normally complain of? It's the worst headache they ever had in their entire life. They may have some visual disturbances, double vision, blurred vision, and they will present like a stroke. Okay, so these individuals, this is serious. And folks that have history of high blood pressure, even patients that have a history of migraines. But yes, this will be that headache that the worst headache they ever had in their entire life. Now, and I'm just going to compare that to a subdural hematoma. They can have a headache, and with a subdural hematoma. So this would be here we go, subdural hematoma. They can have a headache and be confused. Behavioral changes, dizziness, nausea, vomiting. So all of those are, and they could even have a seizure. So here, when we're talking about a subarachnoid bleed, now this is the severe headache, and it's the worst one they've ever had in their entire life. Positive photophobia, just light sensitivity. And they can have vision changes, nausea, vomiting, and present like a stroke. So, ouch. Trying to squeeze that in made no sense. So they can have weakness and things of that nature, hemiplegia, difficulty walking, then have slurred speech, difficulty talking. So they can start having those exact same signs and symptoms. But that's kind of, usually their general makeup. Epidural definitely happens much quicker than a subdural, but neither of these, I would say, definitely the subarachnoid bleed is definitely going to be very significant. The subdural hematoma, people can die from that. It just means that the bleed is a little bit slower But if they're on blood thinners, that even though it's normally a slow bleed, that process is going to be sped up very quickly. Okay. Okay. So talk to me about the contracture. When do we normally see contractures? Or let's talk, before we do contractures, let's talk about contusions or concussions, not contusions, concussions. So if you have a concussion, because we covered that too, are concussions diffuse axonal injuries? And if so, what does that mean?
Yes.
Yes, a concussion is a diffuse axonal injury. And that means every factor of the brain is enduring that kinetic energy from the head injury. Whereas a contusion would be more significant because now all that energy was concentrated to one section of the brain. Does that make sense? Okay. So you can have antegrade and retrograde amnesia. What's the difference?
Is one prior to the incident and one is after to the incident. So retri would be you can't remember anything, or you something like that, right?
It's something like that, but I want to know what it's like.
Retrograde is you remember the accident and everything before. Antegrade is everything, the accident and everything after.
Okay, so actually I think Rodelphine got the first part right. Antegrade, you remember, so take out amnesia. And I tell you, once I did that, it helped me understand what they actually do remember. Okay, so the word tells you what they remember. Antegrade, that means they're gonna remember everything they did up until the accident happened. Retrograde, they remember everything after the accident. So the amnesia is the opposite of what they don't remember. So the amnesia would mean they don't remember anything after the accident, and retrograde means they don't remember anything before the accident. That's why I take out amnesia and only understand what they remember, because the amnesia part totally messes me up. And that's why I didn't even put amnesia, so I didn't mess myself up. But the word before amnesia tells you exactly what they remember. Does that make sense? I know it's quirky, but that's the best way I can help you remember the difference between the two. Okay. So you have those contracture injuries that can happen, or and normally what area of the brain is injured in contracture? Frontal and occipital. That's the coup contracture, but the contracture part is the occipital part. Okay.
Miss Hudson?
Yeah.
So you said that the contracture is the occipital, correct?
That is correct.
And the phenomenon contracture would be the fronto-occipital.
Well, is coup contracture.
Okay.
So the coup is actually the direct injury, which is usually the frontal part that happens first.
Okay.
So when the head hits an object directly, like if they're in a motor vehicle and it hits the windshield because they're not seat belted, then the brain usually thrusts forward. That's the injury to the brain directly. So say, for instance, you got hit by a bat or your head hits that windshield, you're going to eventually go back. So it is kind of like whiplash, but this would be on a more significant scale.
Okay, thank you.
So the contracture usually is that occipital damage that happens from, you know, from the brain being now sloshed backwards.
But you can get hit from behind and still have a coup contra coup. It just
Right, but
happens.
right.
Okay.
You can be rear-ended by a vehicle and still have coup contra coup. But the contra coup part is the occipital brain injury.
Okay.
Because even if you got hit from behind in the car, it pushes your body where? Because
Forward.
it pushes you forward.
I got you. Okay.
So anytime, you know, anytime you have a car accident, there are 3 impacts that happens. The first impact is, you know, car versus car, car versus tree, whether it's frontal, side, or back, doesn't matter. Second thing that happens is, although, you know, say for instance, you got hit and then you hit a pole and you were going 70 miles per hour, your body keeps moving in the car at 70 miles per hour until it hits the interior of the car. So once your body now hits the interior, then it snaps back and then your organs continue to go at 70 miles per hour until it impacts with other structures internally. So all those 3 impacts happen. But even if you get hit from behind, it's going to push you forward and then you're going to go back. And usually if your headrest is in the right position, so where that little hook part of your head is, that's where your headrest should be. So try not to have your ponytails directly back there. But that should actually help blunt your, you know, how much injury you have to the back of the head, to the occipital region. Okay. Trying to remember all of the other injuries there. I did epi, subdural, subarachnoid. All right, so let's do brain tumor. And, well, before we go to brain tumor, last thing, after the concussion, we've actually talked about this. What is post-concussive syndrome? So what things would you assess for after someone has a concussion? What is a sign of post-concussive syndrome?
Well, isn't post-concussive syndrome like if the symptoms of concussion like last longer than like I believe a month or so, and they usually have like the same symptoms, but they're just worse, like insomnia, personality changes.
Okay, so the first thing we're going to look at is what has their memory been like, their short-term memory. Because we won't be able to see that, you know, they're still being the initial phases when they leave our ED. But once, you know, we're going to look at when they're going to return to their baseline after they've had a concussion. So we need to see what their short-term memory is. There are some folks that have concussions that never remember or have flashes of memory, but not complete total memory. So that's all going to vary. But we're going to be looking for declines in level of consciousness. We're going to be looking for declines in headaches and things getting worse, dizziness, seizures, abnormal pupillary responses, which would be like sluggish reaction versus no reaction, any nausea or vomiting, slurred speech, numbness. This lets you know that things are actually getting worse. So the more they have a concussion, so the more concussions they have, this can actually lead to, you know, traumatic encephalopathy, which is that CTE or chronic traumatic encephalopathy that they've been all concerned about, especially with athletes. So, you know, this may present like Alzheimer's, it may present with personality changes, and we're talking about CTE now, which is different than post-concussive syndrome. But the post-concussive syndrome is, you know, that lingering of the concussion, but where they don't, you know, their memory, their short-term memory is, has been impacted. And that's kind of an indicator, you know, of this process still continuing. But they have mental status abnormalities. They're not, you know, which is something we need to assess and then look at all of the other pieces. Do they have any accompanying signs and symptoms related to that? But with CTE, they start having gait disturbances and things like that. So that's a, personality changes, Alzheimer's symptoms, impaired speech, memory impairment. And so when they do get a CT, they will show that they have atrophy, particularly in the temporal lobe. So that will be the chronic traumatic encephalopathy. But for the post-concussive syndrome, we want to look at measuring that short-term memory and then look at other signs and symptoms after the fact. So we're not going to tell them to go home and go to sleep. We're going to actually tell them to go home and have somebody monitor for those things for the next several days, and see if the patient has, any improvement, or do they continue to decline post discharge. So anybody with a head injury, we're not going to let them drive home. We're not going to, we're not going to be promoting, hey, go home and go to bed. We're not going to do any of that. All right. So before I get to brain tumor, let me go one more, I think that I missed, which was a basilar skull fracture. So what is a basilar skull fracture? What are some signs and symptoms of a basilar skull fracture? Okay, what is a raccoon eye? Exactly, periorbital ecchymosis. So they're going to have that periorbital. So basically like a black eye. And the other sign would be post-auricular, not auriculary, but auricular ecchymosis. And I'm going to go ahead and give it the signs that most people will remember. This they would call raccoon eyes. And then battle sign. This post-auricular ecchymosis is bruising on the mastoid process. That's that bony prominence right behind your ear. These are late signs, by the way, okay? Leakage of cerebral spinal fluid. And this could be from the ears. Why did I say eyes after I said ears? Ears, nose, or this can actually come from the mouth. Usually if it's ears, it's going to be bloody drainage, and it's bloody because of the tympanic membrane is ruptured. So how do we know if this is actually cerebral spinal fluid? Well, we're not going to pack anything in the area. We're literally going to let that fluid drip onto a gauze. And so what you would see is a blood spot here. And then the rest of this would be kind of yellow. So this is known as the, let me not need to change color here. As someone has already put in here, halo test or target test. So you may see either or, okay? So we're not gonna pack it. We're not gonna do any of that. This is what we're looking for. But they've had some type of traumatic injury for which the base of the skull is actually been fractured. And so now, if you guys are NASCAR watchers, that's what Dale Earnhardt Sr. died from, was, the decelerative impact when he hit that wall, and then the helmet being not sustaining the head or keeping the head in a neutral position, which is why they have all these upgrades now done to these cars. So, would you, if someone said you do not suction, you test it, that is true. What if the doctor ordered you to, you know, place an NG tube and have it to low intermittent wall suctioning. Would that be appropriate? No. So that would increase ICP. So, you know, making sure the bed is elevated 15 to 30 degrees. You know, we're not going to, you know, pack anything. We're not going to do any of that. So kind of understand how we manage to treat that individual. So, you know, that will cause a huge problem if we start suctioning people like that, and anybody with a head injury doing like routine suctioning every 2 hours and things. We're not going to do that. Okay. So there was a question here. So it won't be. Yes, it won't have blood unless it leaks from the ear. That is true. Now, speaking about drainage. So if you have a patient with a brain tumor that just had a craniotomy, so they just had a craniotomy done. Again, we're not suctioning clients every 2 hours because that's going to increase ICP. But if the dressing to that craniotomy is clear, what should we do if we saw this clear drainage to the dressing of a patient that just recently had a craniotomy done? Test for cerebral spinal fluid, test for glucose first. And you're right about the cerebral spinal fluid, but it's really going to be a glucose test because that lets you know that it is cerebral spinal fluid, and then you're going to call the doctor, because calling the doctor and saying, hey, I'm looking at this dressing and it's clear, because what is he or she going to say? So is it cerebral spinal fluid? And you're gonna be like, I don't know. So to find out if it is, then if it has the presence of glucose in it, then yes, this would be cerebral spinal fluid. And then we're going to definitely tell the physician that this is what we have, okay? If someone has an occipital brain tumor, can we, and knowing what we know about what the occipital portion of the brain does, if we give them morphine for pain management, would that be a good or bad thing? We're not going to give them morphine. We're not going to give them the morphine because the morphine is going to suppress their respirations. And if we decrease respirations, we could increase what? ICP and CO2, yeah. So basically, no morphine, no MSO4, with an occipital, brain tumor. This decreases respiration, which increases ICP, which is what we don't want to have happen, which would entail increased CO2. And if we increase CO2, then is that helping us perfuse our brain? No, because that's a potent vasodilator. So we could give ibuprofen or Tylenol or naproxen. We could give those. So since we're still on brain tumor, what if we had a kiddo with a brain tumor? How would they present? I'm just going to say BT, signs and symptoms. Let me change color too. Nope, got that color because we can't see. So what would be signs and symptoms with a kiddo with a brain tumor? Classic signs. So headache, okay. Headache, vomiting. They could have some extremity deficits depending on where it is. Lethargy. Oops. Their head may tilt, and that would be that epithetonis. So if they have an increase in ICP, then they will be bradycardic because they're normally tachycardic already. Yep, they can. So if you do have a patient with hydrocephalus, speaking about increased head circumference, we want to definitely measure that for VP shunts, you know, if you have someone with hydrocephalus. So for possible infection, then, but if the person was normally active and talking and now they're not responsive, then we need to call the doctor. So if you have a kiddo that has, I'm gonna clear this here. If you have a kiddo that has not ICP, a VP shunt. So they have a VP shunt. It was just placed 48 hours ago. And now the patient has a bulging fontanelle. Is this normal? No, this is not normal. So what types of things, so you're giving the doctor an SBAR. So under recommendations, what would you recommend? Okay, so before we need to remove it, what do we need to do before that? Okay, CBC, check for infection, x-rays. Okay, so CT scan. You may do shunt x-ray series. Or you may actually, you know, tap the shunt and test it for, you know, malfunction. So you can actually test it for a malfunction. So that would be the recommendations. They know, we have to figure out what the problem is. So we need to get the diagnostic studies and tools that's needed in order to, you know, correct that problem. Okay, so say you have a person that has a closed head injury and, you know, they've been depressed for weeks. So, you know, this would be a teenager. They've been depressed for weeks and, you know, they've been at home convalescing with this thing. What can we recommend to maybe help boost this person's spirits? Okay. Yeah, if the person's been kind of convalescent at home, let's get some people over there to visit the individual, you know, especially if they're starting to get depressed. Some of these things take some time to, you know, to resolve. So, you know, let's get some people over there to kind of talk to them and see how things are going and get some interaction and things of that nature going so the person doesn't isolate themselves. You know, we don't know what the final deficits of that will be, so we need to, you know, kind of get things rolling on that end. So all right, let's see, got 5 minutes. Say what? Unbelievable. So don't forget to look at your seizure stuff. You know, what is the best medication to treat status epilepticus? Ativan. And what is the generic name for Ativan? Lorazepam. Somebody said they started with Laura. I saw that just a bit ago, Laura. So lorazepam. So you forgot the Z there, Kavita. But you were close, lorazepam. You're fine. So don't forget to look at the different seizure types, seizure meds, how to stop seizures. You know, I can't believe time has gone this quickly. I was like 3 hours. I'm like, I don't think it's going to take 3 hours. So like, we could have been in here all day with this.
Miss Hudson?
Yes.
Well, we need to know like specifics about what medicine will treat what type of seizure, or just basically other than like the status epilepticus.
I would know classes that we talked about earlier.
Okay.
So, and at least know, you know, your barbiturates would be that phenobarbital. So your barbitals, I think that's pretty simple to understand. And that you need to check levels. That's important. You know, if their patients on if they're on phenobarbital, if they're on Keppra or whatever, that, you know, that would be something that you would actually need to do. We did start off with a lot of the death and dying. So, you know, we talked about grief and loss pretty significantly as well at the last lecture. So I think you guys kind of have those, you know, on lock. I'm trying to see what else is there that I can think of. I covered Bell's palsy and TIA. I didn't talk a lot about Parkinson's, so, you know, it doesn't mean that that's not on the test. It's just I didn't have time, as you can see in this 3 hours. I can't even believe that, to cover that information. So it's, you know, it's still there, but I'm hoping that this kind of helped you guys, you know, ground yourselves, solidify things that you know. I wanted to address the TBI trauma piece, as I've gotten some feedback that some of it was zipped through really quickly, some of it, you know, wasn't really explained. So just wanted to kind of circle back on that to make sure that, you know, you guys are prepped and ready for Monday. So hopefully this really did kind of hone you down some, or hone in the information better. The form is available. It's in community under forms.
But Miss Hudson,
Yes.
I don't know if I'm the only one, but I'm not able to download that form. Like when you click on it, nothing happens.
I've received forms, so I'm not really sure. I will double check that though. But I have already received forms from individuals. Let me look in community right now again to see if there is actually a deficit there. And I'll look at it from the student's view versus the faculty view. But you send it to me, and I have created a no questions asked folder, so that way if you decide that you want to withdraw it, then I know where to pull it from. I don't have to look through all of my emails to find your name.
Ms. Hudson?
Yeah.
Now, while you look for that, I wanted to ask you, as we sign up for HESI, the date for ours is the 13th of May, correct?
Mm-hmm.
Okay, just because, and you said that the time has to be between 8 and 10 a.m., correct?
Preferably, yes.
Okay, because I
But
think
whatever your time that you sign up for, if it's 9:20, then your exam starts at 9:20.
Okay, but it has to be the 13th regardless of the fact that the submission link has it open until the 16th, correct?
That is correct.
Okay, thank you.
Because your date is the 13th. All right, so I'm in community. I'm going to forms, which is like the 5th button down. All right, and I'm going to go to student view. So when I go to student view, I was about to freak out here for about 2 seconds. Sister. there's a tab, but it is not available. Lord have mercy. All right, so I will find out. I will make this available. I don't know what happened there, but let me locate that form. My apologies, because like I've already gotten the form, so I'm like, how are people getting the forms if it's not available? So I don't know what happened there. So my apologies deeply, Rodolphine. I will look and add that to it. So just like I'm going to go to student view just to make sure, not looking at it from the faculty view. So once the grades are posted for exam 4, and then I'm going to have a brief conversation before we wrap up. Then you have 48 hours to submit your form to me on and you need to identify which exam you are asking to retake. If you did not take this exam originally, you do not fill out a form for that. You're already on the list for the makeup. So this is for an exam that you actually took at the original scheduled date and time. So that's what the no questions asked form is for. So hopefully that clears that up. So let me explain why you guys have received in the last 3 days a lot of this information about PrepU and cameras and things of that nature. This will probably answer, I think this was Tom's question about why we don't do one-to-ones, and why we're doing now we're only allowed to do high miss questions, and this may not have even been your question, and I'm sorry for that. There have been some individuals that have been identified as cheating. If your camera turns off, you better find a way to turn that sucker back on during the test. So check your cameras, make sure your cameras are fully charged or plugged up or whatever the case may be. There is a way to make sure that, yes, the Methodist group will send it to Mrs. Johns. But ECC in North Lake will send your no questions asked to me. So make sure your face is in the camera view, and there's a button that you can click to make sure that you're actually in the camera view. Make sure you don't go off camera, because that's going to be another problem. And, you know, I don't have a problem with you talking out the questions, but your family can't be in the background, walking in the background. You need to be in a room, not in your kitchen, where that's a highly populated area. So there are things that, you know, you're thinking that they can't see or they don't know, but they do. But if for some reason you lose connection, then you need to, you know, contact myself, and then both Chris and Ms. Rattan will be available to help assist with any deficits that you may have. But this is serious, guys, and I really hate that you all are in this position, but there have been some people that have been exited out of their programs, out of their levels, for cheating. So let this not be you guys, okay? Because that would be very sad. That is a district policy for academic integrity. So you may not have signed a form saying that, but as far as the district is concerned, everyone will have integrity and not be disingenuous. So yes, they are reviewing all of the video footage, and ProctorU is specifying areas in the video for which they find abnormal irregularity. So that's the whole crux of that. But I will just say the majority of if you don't upload your video, there were several of you that did not upload, but we're asking you now to leave that open for at least an hour. So that way the video can actually upload, and that could just be your internet feed or however the case may be. But we do need that video to be uploaded. And I don't think you want to get a 0 for not having that form or having your video not load. So that would be the most stupidest thing of all time. It's kind of like getting arrested for breach of peace. That's the cheesiest thing you can get arrested for. Not that I've been arrested, but just saying. Make sense? We are allowed scratch paper. You are allowed what was posted in the announcements. So there was one just specifically, and I believe Mr. Bobbitt actually came back and clarified what you can have for HESI, not for the exams. So make sure you read, there's two different policies. There's one for your lecture exams, and then there is one for HESI. And they are very similar, but they read differently. So you need to make sure you look at the difference between the two. So lecture exams, there was no paper. They stuck with that. But for HESI, they were allowing paper. So, but don't have your notes, don't have multiple screens, multiple monitors, things like that are definitely being identified. Do I need to contact ProctorU if in the test my monitor and it says my internet is slow? I would be contacting Ms. Rattan, and you guys already have the link. It was posted out it was posted out in community. So that would be the place to go if you have issues. Yes, Mr. Flores. Go ahead.
So I'm looking at the forms right now.
Uh-huh.
The acknowledgement form, it says on the lecture, it says you can have a piece of paper.
Okay. If it's there on that form, I thought it was no paper, but they may have forgotten
Number
that.
3.
Okay, I will look at that again. Right now it's too late to be changing it. But at the top of it, one says exams and the other one says HESI.
Yeah, one says a lecture and one says HESI.
Okay, so is this the one for lecture?
Yes, ma'am.
Okay.
It says you may only have one sheet of clean paper to begin your exam.
There you go.
When authorized by your coordinator for math exams.
Oh,
This
that's
is
for
not a
math exam. That's
It's a
the math
lecture
exam. That's the math exam. That's not for the math on the exam. That's for your regular math exam. That's what I said. I didn't think that was there.
Okay.
So I'm glad you brought that up because that would have definitely been, I could see how that could be misinterpreted, but that's for the math part.
For the math exam, not the math part.
Correct. You take your exam and exemplify. So someone else had that question earlier in the week. So you go to exemplify just like you normally would. But ProctorU is monitoring it in exemplify. So you don't need to go to their site. You need to go to the exemplify site.
Ms. Hudson, once the test opens up, we can start taking it. We don't have to wait to be.
Nope.
Last time I was waiting for somebody to tell me, okay, go. So I lost like 5 minutes, but.
No, once you open it up and you're rolling, you keep going.
Okay.
So what I would do is test the camera. It shouldn't turn anywhere if it's clipped to your computer. Now, if you don't know, like I have my cameras already built into my laptop. So, and unless I move my laptop, that's the only way my camera moves. But if you have a clip-on camera, the one that attaches to the top, then if you're not moving anything, then it should stay in place. So that should not be a point of, your camera shouldn't go anywhere. I can't do anything about the paper thing at this point in time. So I'm sorry about that. That was, I fought for it, but I can't do anything. It turns on through the exemplify. Yes, when you take the test, you're going to have a series of checkpoints. So I'm going to say log on about 15 minutes early. Get all your little check pieces done, all your ID check, and then you should be ready to start. And there's a light, there's a button that you can push, and it'll actually flash back on your screen exactly where you are in the camera view. So it'll tell you where you are. Mr. Flores, I saw your hand was up again. Yes.
So on the HESI, I'm sorry to keep bringing this up, on the HESI acknowledge form, it says the same thing, a clean piece of paper when authorized by your coordinator for math exam. So,
but Mr. Bobbitt also sent out the one what you can have for HESI. So that is actually listed on your course board because I posted it. So when you go to your announcements for your lecture section, it says this is what you can have for HESI. So I understand you want the paper, but I can't give you the paper for that. But
no, it just said to sign these forms and upload them. So I want to make sure I'm signing the correct form. I don't want to sign something
and be in trouble.
And and be in trouble.
Yeah, you won't be in trouble for HESI because it was posted in your course board about being able to do the HESI with one paper. That was there. So, and I would actually fight for that because I saw that. I posted that myself. So I wouldn't let you go down in flames.
Okay.
So usually if I halt you if I stop you from something, then that means you're probably going down the wrong road. But if I know that you may not understand something and I halt you and I'll say, hey, okay, now hang on a minute, then that I'm letting you know you're missing something. But yes, they did post that to say that you can have certain things for HESI. Okay. There's 2 more questions, but I'm not sure who raised their hand. I got to see if I can find that. So no, Mr. Flores was one, but I couldn't see the second person. Who was that?
Sorry. I have another question for you, Ms. Hudson, probably the last one. So just for clarification, I don't know yet if I will need to take another exam. So when would be the last possible time to turn in the retake? Because I would want to wait till comp and see how that one goes, but I don't know if there's a deadline for it.
Okay, so yeah, I sent that. So it was titled No Questions Asked, Clarification. So you have 48 hours after exam 4 to submit your document. So if I release grades, say, Tuesday at noon, you have until Thursday at noon, that'd be a whole 48 hours to submit your no questions asked test. That following Monday, you will take comprehensive. And so if grades are released, and I will try to do those quicker because you have the makeup exam on that Wednesday. So then you would have, if I release them Monday night, you would have until Tuesday night to say, I don't want to take the test, because your next test will be on Wednesday for the makeup.
Okay, so then it would be like last semester. If you
Yeah,
didn't
24 hours.
withdraw it, you would get a 0 because technically you signed up to take it. But
Correct. So you need to let me know, please withdraw my request for exam blah, blah, blah makeup. So exam 1, 2, 3, or 4. It's not for the comprehensive and it's not for HESI.
Okay, perfect. Thank you.
All right. Was there another hand that was up? Okay. So let me look for that paper. I will send an announcement to say that, it's available, and then go from there. Again, my apologies that that's not linked. So I will find the link for it, connect it. And then if you have any other questions, just shoot me a text or shoot me an email. There were some emails that I did receive to be answered during this session, and I hope I've answered those. It was in reference to meningitis. So I hope we got those answered and cleared away for the individuals that did that. So other than that, try to have a happy Saturday, and we'll see you then.
Thank you.
You guys are welcome.